Hi everyone, welcome to PsychWatch YouTube channel which discuss about psychiatry, psychiatric nursing, psychology and various topics related to this. Today we are discussing about one interesting topic which is very relevant for our public too, because many are affected with this problem, but they are not aware that they are having this problem. They may be visiting various number of hospitals and doctors without knowing that this is a disease that actually linked with the mind. As we know, this mind and body is interconnected. Even our forefathers identified the relationship between mind and body. And now modern medicine clearly identified the role of mind in body's health and role of body in mind's health. So we will discuss about somatoform disorders. Somatoform disorders, somatization disorder, conversion disorders, dissociative disorders. These are some of the terminology that we use interchangeably. Knowingly or unknowingly, even the professionals use the word psychosomatic disorder in this place. But psychosomatic disorders are not coming under this area. As we move on with this topic, we have to identify one more term, that is fictitious disorder or Manchester syndrome. Here the person assume physical illness, or they believe themselves as having physical illness with a gain to get a sick role. So that is what is Manchester syndrome. Coming to definition, somatoform disorders are characterized by physical symptoms which suggest medical cause or medical disease, but without any organic pathology. The person may come with various symptoms. Actually, these symptoms may mimic some physical problem. But even if he undergo various investigations or tests, we cannot identify any specific organic pathology. According to International Classification of Disorders, various categories are there under somatoform disorder: somatization disorder, undifferentiated somatoform disorder, hypochondriac disorder, somatoform autonomic disorder, dysfunction, heart and cardiovascular system disorder, upper GIT disorder, respiratory system disorder, genitourinary system disorder, other organ system disorders, persistent somatoform pain disorder, other somatoform disorders, somatoform disorder unspecified. So this is according to ICD. Now we will see based on DSM how it is classified. Under DSM it is somatization disorder, undifferentiated somatoform disorder, hypochondriasis, pain disorder associated with psychological factors, somatoform disorder not otherwise specified, body dysmorphic disorder and conversion disorder. So in both cases many terminologies are overlapping. Now in order to remember for exam purpose, I will give you a clear classification. So it would be easy for you to remember. So first one is somatoform disorder. Under somatoform disorder, somatization disorder, hypochondriasis, somatoform pain disorder, body dysmorphic disorder. So these are the 4 things that is coming under somatoform disorder. Under conversion disorder, it is conversion ataxia. The person may not be able to move or stay steadily. Conversion paralysis, a particular part of the body is paralyzed. Conversion anesthesia, here the person will not feel the sensation in a particular part of the body. Aphonia, conversion aphonia, person not able to speak. Blindness, conversion blindness, here the person may not be able to see. All are associated with the psychological factor. Even if you analyze, even if you test those individuals with this problem, you may not be able to identify any organic pathology. So that is what is conversion disorder. Next one is dissociation disorder. Under dissociation disorder, dissociative amnesia, the person may not be able to remember, general loss of memory. Dissociative fugue, here the person may take another personality and will live like another personality after forgetting everything or every aspect of previous personality. For example, now I am so and so, so I will forget about everything of current life, relationship, everything. Then I may go somewhere else and live like a new person. That is what is dissociative fugue. Then identity disorder, the person may take 1 or 2 identity personality and he overlapping type of personality disorder. Sometimes a person may behave like this and some other time he may be showing another personality. Then trance, here the person may take something is that is it is otherwise known as possession disorder. Something is possessed, he may speak or he may behave like another person's spirit. So that is there. Derealization and depersonalization. In derealization, the person may feel that nothing in this environment is existing, and in depersonalization, the person may believe or perceive that he himself is not existing. So that is about dissociative disorder. In somatoform disorder, I told you that is somatization disorder, hypochondriac disorder, pain disorder, and body dysmorphic disorder. We will see one by one. First one is somatization disorder. So from its definition itself, it is clear. In somatization disorder, it's a syndrome of multiple somatic symptoms that cannot be explained medically and are associated with psychosocial distress and long-time seeking of assistance from healthcare professionals. See, the person is affected with multiple symptoms and he may seek medical assistance because of this medical illness, what he say, medical illness, he may have lot of psychological distress. So to get rid of this distress, he may seek medical assistance. That is what is somatization disorder. Few features are there in order to diagnose. First one is pain at least 4 different parts of the sites. Different sites he may experience pain, at least 4 sites, like head, chest, back, joints, pelvis. If a person is affected with this particular disorder, he may complain or she may complain that he or she is having pain in multiple, at least 4 places. Then gastrointestinal symptoms, he may complain. Gastrointestinal symptoms like nausea, vomiting, diarrhea, all those things, regurgitation. So these are the features, gastrointestinal features. At least one will be present. For pain, 1 GIT. Then he may have or she may have sexual problems. It may be like irregular menses, ejaculatory problems, or even sexual dysfunctions can be there. For pain, 1 gastro, 1 sex related problem. Then symptoms suggestive of neurological conditions. Here the person may have paralysis, blindness, dizziness, or deafness. So this is what is happening in somatization disorder. The person may complain of these physical symptoms. It is nothing to do with any real physical problem. It is something related to psychological. So regarding epidemiology, So somatoform disorders not known actually how many percent of individuals in the society is affected, not known. But it varies from culture to culture, country to culture, country to country. It is estimated that 2 to 16% of the populations are affected with various disorders, somatoform disorder. It can be somatization disorder, it can be body dysmorphic disorder, it can be hypochondriasis, pain disorders, conversion disorder, or dissociative disorder. And few disorders like somatization and somatization disorder and pain disorders are more commonly seen in female, whereas body dysmorphic disorder, hypochondriasis are more commonly seen in male. Now regarding etiology, various etiological theories are there which tell us about why this happens. And biological theories are there, neuropathological theories are there, genetic predispositions are found to be acting on such individuals, and of course psychological theories. All theories tell us about how it happens, why it happens. Then social theories are there, that is also explaining it as an etiological factor. Then theory of family dynamics. I told you the person is affected with the physical symptoms. Actually the cause of these physical symptoms are psychological, so definitely family plays a major role, family dynamics plays a major role. Then cultural and environmental factors influence. Then of course transactional model of stress adaptation. If the person is not able to adapt to stress effectively, depending upon the levels in which he is communicating with the others, that is transactional model tells us about all these things. We will discuss this transactional model in another video. Regarding diagnostic criteria, there should be history of physical complaints before the age of 30. That is very important. Usually that happens before the age of 40. Before the age of 30. And it can last for several years. And even if the person take this treatment for a long period, he will not get rid of this one. So most of the time, patients may go for doctor shopping. That is one of the important characteristics that will help you to identify such disease or diagnose such disease. And because of this problem, the person may be totally disturbed, and there is possibility of impairment in social functions, occupational functions. All areas of functionings are affected because of this illness. And as I told you, for pain, 2 gastrointestinal system problem, sexual problem, or pseudo neurological symptoms should be there. Then only we can diagnose such conditions. One thing you need to remember, these symptoms are not intentionally developed. There is one confusion. Even if the person undergo various tests, they will come, or results may come as negative. The family members may say, oh, it is because of his action. Actually he is acting, he don't have any problem, he is voluntarily doing like this. No, it is nothing to do with the volunteer action. It is unconscious one. Involuntarily this happens in that individual. The person is not consciously doing this. So that is very important. Except in Manchester syndrome, that is in malingering, where the person may be saying voluntarily saying that he is having this problem. Then regarding treatment helping the patient to understand that symptom that does not actually because of any physical problem. So you need to teach them. Psychoeducation is very important, so that we can make him convinced that this is nothing to do with the physical problem. Then promote functioning, because it is affecting the normal functioning. So as a nurse or as a therapist, you need to promote functioning. Then cognitive and behavioral therapies are equally effective. Psychotherapeutic treatment mainly, or psychopharmacological agents mainly, it is antidepressants. Antidepressants are found to be effective for such patients. Now regarding nursing management is very important, because a nurse can do a lot. establish a therapeutic relationship with the client, accept the client as he is, then starts. The first thing what a nurse has to do in nursing process is detailed assessment. Assess the symptoms, what the patient is complaining, then assess the functional impairment, because most of the time patient may come to the hospital because of the problems related to family impairment or functional impairments. Then you remember you need to assess secondary gain. In the somatoform disorder or somatization disorder, primary gain is there, secondary gain is there. Primary gain, that is he is affected with this disorder, so that he will get that care and everything. Secondary gain, he need not to take his responsibility. So definitely you need to assess the secondary gain possible for that individual. That is very important. Then premorbid personality. During this assessment, you need to assess the patient's premorbid conditions. How far he was adjusting with the life stressors. How far he was using these resources, coping mechanisms. So all those things. Then comorbid conditions like anxiety, whether the person is affected with some comorbid psychiatric conditions. Depressions can be there. Obsessive compulsive disorder, commonly seen in such patients. Then substance abuse disorder. All these things you need to assess. Then finally, treatment history. That is also very important because I told you, with this problem, client may go for hospital shopping or doctor shopping. So that we need to pick out. That is an important clue that you will get to diagnose, or that will help you to diagnose this somatoform disorder. Now, next one is nursing diagnosis. Because of this problem, you can diagnose fatigue, pain, disturbed sleep, self-esteem, self-care deficits, ineffective coping, ineffective individual coping, individual family coping, dysfunctional family process, altered parenting, powerlessness, social isolation, ineffective regime management, therapeutic regime management. All these nursing problems you can elicit in a person with this somatoform disorder. Then management. Apart from a routine nursing care, you can have counseling sessions. Counseling is very effective for such patients. Psychoeducation. So it may take multiple sessions, but psychoeducation is effective. Self-care promotion activities. So try to teach the client, help the client to regain his self-care activities. So that is very important. Activity enhancements. Relaxation therapy, because the person is stressed, he is anxious. So what all you teach him as relaxation therapy will be very useful for such patients. Of course, pharmacotherapy, drug of choice is of course antidepressants. Then pain management and various psychotherapies like behavioral therapy, cognitive behavioral therapy, group therapy. All these things will be useful for such patients with this somatoform disorder. So somatoform disorder, very important. Under this somatoform disorder, somatization disorder we discussed. Now we are moving towards hypochondriac disorder. That is also very important. Here the person will perceive normal physiological functions as pathological, and it will be ending with psychological distress, mental distress, and it will affect all his functions. Like hypochondriac is characterized by 6 months or more general and non-delusional preoccupation with the fears of having idea that one has serious disease based on the person's misinterpretation of bodily symptoms. He interprets his bodily symptoms as pathological, and it will affect his normal functioning. He will not be able to live normally thereafter because he is always preoccupied. Nothing to do with the delusion. He is preoccupied with the bodily functions as pathological. It is onset of disorder mostly in 3rd or 4th decade of life. After 30 or after 40, usually people may get this hypochondriac disorder, which is commonly both sex are affected, that male and female are equally affected. Slightly highly prevalence in people with a lower education and income level. That is, usually we can see low income level patients or people with low socioeconomic status and educational status usually can report to have this hypochondriac disorder. So hypochondriac disorder is nothing but the person perceives his normal bodily functions as pathological, and he will be preoccupied with that pathology, so-called pathology, and affecting his normal affecting his all levels of functions. Now regarding etiology. So etiological factors, that is psychodynamic theory, cognitive theory, social learning theory, past experience with a physical illness, genetic influence, all these things explains why such condition happens in an individual. So regarding diagnostic criteria, how we can diagnose? According to DSM, preoccupation with the fears of having or the idea that one has serious illness based on person's misinterpretation of bodily symptom. So here the person will be preoccupied with the pathological issues. Actually it is normal physiological function. Then the preoccupation persists despite appropriate medical evaluation and reassurance. Even if the person undergo various assessments, various investigation, and all these investigations or tests will be found to be, even if it found to be negative, normal, he will not be satisfied. So that is another criteria. The belief in criteria A, that is first one, is not delusional intensity and is not restricted to circumscribed concern about the person. It is nothing to do with some specific area. The preoccupation causes clinically significant distress. That is very important. So because of this preoccupation, person may be in distress, may not be able to live normal life. And clinical features. Patients have a serious disease that has not yet been detected. The feeling, the person may perceive that he has a serious illness. It is because of the problem with the medical system. The diagnosis is not being made. So that is the concept what is inculcated in that individual. This conviction persists despite negative laboratory results. Even if the tests are negative, that concept will not be changed, often accompanied by symptoms of depression and anxiety. Such patients always anxious, and they can have depressive symptoms too. But remember, if a person is coming with such problem, always do differential diagnosis. In differential diagnosis, it is somatoform disorder, somatization disorder, conversion disorder, pain disorder, depressive disorder, delusional disorder. All these things need to be differentiated before coming to conclusion that this hypochondriasis is the diagnosis. Usually it is episodic. Sometimes there will be some sort of relief. Again, that symptoms may come back. It is episodic in nature most of the time. A good prognosis is associated with a high socioeconomic status, treatment responsive anxiety and depression. That means I already told you this is more commonly seen low socioeconomic status. Even it happens in a person with high socioeconomic status, the chance of prognosis is better. And if that anxiety and depressions can be manipulated with the help of treatment, that means we can say he is with a better prognosis. Now regarding treatment for this hypochondriasis, it can be group therapy. Group therapy is very effective because in group setting these symptoms are better controlled. The individual insight oriented psychotherapy is effective. Behavioral therapy, cognitive therapy, hypnosis. So these are some of the treatment modalities that we can use for such patients. So nursing management, as I told you, detailed assessments, diagnosis, previously I told you, then of course intervention. Then a detailed evaluation is very important, and based on that evaluations you can decide whether to continue that interventions, modify the intervention or terminate the intervention. So that's all about hypochondriasis. Now, autonomic dysfunction, somatoform autonomic dysfunction. It is very important. So, in this somatoform autonomic dysfunction, the symptoms are presented by the patient as if they were due to physical disorders of organ system that is predominantly under the autonomic control. Actually, it is autonomic control. We don't have any voluntary control on that one. And he may believe that a person have a problem in that organs which is controlled by autonomic nervous system, like heart, cardiovascular disease, GAT problems, respiratory system, genitourinary system. Then in all these symptoms, all these system complaints based upon the objective signs of autonomic arousal such as palpitation, sweating, flushing and tremor. When the person experiences this palpitation, when the person is experiencing tremors, when the person is experiencing flushing, sweating, he may think that it is because of the disease related to that particular organ. Usually it is heart disease, GAT disease, respiratory disease, genitourinary disease. So he may suspect like that. Now, hyperventilation syndrome. In hyperventilation syndrome, which is characterized by habit of hyperventilation, which becomes particularly marked in the presence of psychological stress or any emotional instability. Here the person, during the time of stress, he will show hyperventilation. So it will end up with so many problems like fatigue, chest pain, headache, palpitation, sweating, feeling of lightheadedness, then paresthesia, loss of consciousness. So these are the symptoms that the person can exhibit when the person is with this hyperventilation syndrome. The treatment of choice is breathing technique, very important. Breathing more from the abdomen, thus avoiding the use of accessory muscles of expiration. So try to teach them to take breaths using these abdominal muscles. That will ease the chest muscles from increased use. Then slow respiration with passive expiration without muscular effect, and make the person to use a paper bag and ask him to use that paper bag and during this breathing. That will also help in getting relief from this situation. Then you can, that is what is known as breathing bag technique. Of course, you can teach them relaxation technique. Various relaxation techniques are found to be effective for such patients. That is also useful. Next disorder under this somatoform autonomic disorder is irritable bowel syndrome. Here the person may complains with abdominal pain, discomfort and cramps, alteration of the bowel habits, a sensation of incomplete evacuation. Then the person treatment is of course a stable and a trustful doctor-patient relationship, nurse-patient relationship, supportive psychotherapy, identification of current stressors, anti-anxiety drugs, antidepressant drugs. Symptomatic management is very important. Usually the person is with a lot of anxiety. One of my friend, actually he had this problem and we used to make fun of him, like saying he will be anxious always. Sometime if he is not anxious, then he will think and he will become anxious by thinking that why am I not getting anxiety. So that is the type of personality, that is the way people may think these situations, and that may be the reason for this condition, or that is the way symptoms exhibits in patients with irritable bowel syndrome. Next one is premenstrual syndrome. That is also belongs to this group, characterized by variety of physical, psychological and behavioral symptoms occurring in the second half of menstrual cycle. Here the individual may affected with these many symptoms. Then the symptom starts after a few days of ovulation, reach a peak at 4 to 5 days before menstruation and disappear usually around menstruation. So it is before the menstruation person are experienced with these symptoms. The period between menstruation and next ovulation is usually normal. So just before the onset of menstruation, people may get these premenstrual symptoms. Then clinical features: feeling of irritability, depression, crying spells, restlessness, anxiety. So one important thing is, if a person is affected with the borderline personality disorder and affected with these premenstrual symptoms, the risk of suicide is very high. So that is very important. Now, changes in appetite. Usually with this premenstrual symptom, people are affected with the change in appetite. Signs and symptoms of water retention, gastrological change, gastrointestinal changes, headache, fatigue. So these are the clinical features that you may get. Of course, etiological factors are biological factors and psychological factor. In biological factor, it is because of the excess of estrogen, faulty utilization, progesterone deficiency. So these are the biological factors that can cause premenstrual symptoms. Psychological factors include, it is education. During the time of this education, girls are more affected with this problem. Attitude towards menstruation and family. That is another important psychological factor that influence such condition. Treatment is, of course, for treatment of water retention, diuretics is the treatment. Psychotherapy is found to be effective. Hormonal therapy is important. And in resistant cases, mild lithium, bromocriptine, antidepressants and anti-anxiety drugs are found to be effective. So that's about premenstrual symptoms. Next one is pain disorder. It is very important. So next one is pain disorder. A pain disorder is characterized by the presence of and focus on pain in one or more body sites and is severe enough to come to clinical attention. Here the person may complaining of severe pain in one or two areas. The essential features of pain disorders: severe prolonged pain that causes clinically significant distress or impairment in social, occupational and other important areas of functions. So the person is experiencing pain and which is affecting his normal physiological functions and he is not able to function normally. His functional impairment is the main thing that is affected with the pain disorder. Now we can see the psychological implications of pain disorder. There are primary gains and secondary gain. I already explained. Primary gain: appearance of pain enables the client to avoid some unpleasant activity. So once the person is affected with the pain, he needs not to do certain household activity. That may be the primary gain. The secondary gain: the pain promotes emotional support or attention that the client might not otherwise receive. Once the person is affected with this one, others will come and consider them. They will get some sort of care and support. So that is what is secondary gain. So in pain disorder, primary gain and secondary gain is very important. Now, etiology and predisposing factors for this disorder, pain disorder. That is what is, first one is psychodynamic theory. Very well explains about it is my past decides my present. Something happened in my past causes current problem. Behavioral theory. Behavioral theory teaches that it is a learned behavior. Something learned in the past. It can be explained by classical conditioning or operant conditioning. That we will discuss in another video. Then theory of family dynamics. In theory of family dynamics, it is because of the family disharmony, dysfunction, the person develops such condition. Neurophysiological theory tell us it is abnormal neurotransmitter, abnormal release of neurotransmitters. Everything contribute such condition. Then of course improper stress adaptation. That is another important theory which explains the etiology of this pain disorder. Clinical features of course is low back pain, headache, typical facial pain, chronic pelvic pain. These are the main areas where the patients may complain with the pain. Now, differential diagnosis, that is very important. Once you identify, you need to identify or you need to rule out physical pain, because it can be because of real physiological or physical disorder. You may get problem. Then hypochondriasis, conversion disorder, all these things you need to rule out. Now regarding treatment, pharmacotherapy, psychotherapy, other therapies and pain control programs are very effective. Anti-anxiety drugs, antidepressants, and sometimes mild antipsychotics may also be useful for such conditions to control pain. Next one is nursing diagnosis and nursing management is similar to that of other conditions, that is detailed assessment, diagnosis and implementation and evaluation. Now conversion disorder. Conversion disorder is an illness of symptom or deficit that affect voluntary motor or sensory function, which suggests another medical condition, but this is judged to be due to psychological factor because the illness is preceded by conflict or other stressors. That means previous one, autonomic bodily, the organs which is supplied by autonomic system, which normally a person don't have any voluntary control, is affected. Whereas in conversion disorder, the voluntary muscles are affected, where usually a person uses these voluntary muscles and that function of that particular area is impaired. But remember, there will not be any physical cause, it is purely psychological in origin. So that is what is conversion disorder. The symptoms or deficits of the disorder are not intentionally produced. Remember, nothing to do with the intention. The person is not showing this disorder intentionally. Now we can see the etiological factors of conversion disorder, that is psychoanalytical theory explains, behavioral theory, neurophysiological physiological theory, family theory and stress adaptation, improper stress adaptation very well explains about occurrence of this conversion disorder. Now regarding clinical features like paralysis, blindness, mutism. In paralysis, one particular part of the body is paralyzed, it's not functioning. Blindness, the person is not able to see. I have seen a patient, she was actually one MBBS student. During the time of examination, she is not able to write, and she came to the OPD and finally diagnosed to have this conversion disorder. That particular voluntary muscles to that hand is affected. Actually, she was very good at studies, but during the examination time, she was not able to write. Then mutism, not able to speak. So that is also seen in this conversion disorder. Regarding sensory symptoms, anesthesia, paresthesia, deafness, blindness, tunnel vision. So these are some of the sensory symptoms that we can see in such patients. Then regarding motor symptoms, ataxia, paralysis and paresis. Then in some cases it is seizure symptoms, pseudo seizures, very important. Then other associated features are primary gain and secondary gain. Now we can see what are the differential diagnoses for this conversion disorder. It is neurological disorder, somatization disorder and hypochondriasis need to be ruled out. Then regarding treatment, medical and psychiatric history is very important. Full examination and appropriate investigations to rule out any physical causes. Avoidance of reinforcement of disability or symptoms, very important. If you are giving more attention to the symptoms, there is a risk of continuing that symptoms, because that behavior shown by the therapist will reinforce such behavior. So very important to very cautious about not supporting such behavior. That is very important. Then discussion of the expected rapid recovery. Sympathetic but positive reassurance is effective. Symptoms persisting for more than a few weeks. So elimination of factors that are reinforcing the symptoms. Encouragement of normal behavior. We need to encourage normal behavior. Regarding nursing management, detailed assessment as we discussed in somatization disorder. Diagnosis similar to that of somatization disorder, which we discussed in detail. Intervention or those therapies or counseling, everything can be applied here also. Then of course we can have evaluation, and based on that evaluation we can have final conclusion whether to continue with this continue with the therapy or to modify the therapy or to change that therapy, everything based on that evaluation. Next one is body dysmorphic disorder. Body dysmorphic disorder is characterized by preoccupation with an imagined defect in appearance. The person may think that there is some defect in the appearance that causes clinically significant distress. So because of this thought, person's normal functions are impaired. All the functional impairment you can see, that is functional impairment in occupation, functional impairment family, functional impairment personal life, everything is affected. If a slight physical anomaly is actually present, the person concerned with the anomaly is excessive and bothersome. So that means usually people may preoccupied with the bodily dysfunction or that is a physical anomaly. The person may think that that particular part has got a disproportionate with the other part of the body, and sometimes person can have little bit difference, and he may exaggerate that condition and will end up with a total problem. Community prevalence is between 1 to 2.2 percentage. See, 1 to 2.2 percentage of the population is affected with the body dysmorphic disorder. Most common age of onset is between 15 to 30 years. Usually it's seen in between 15 to 30 years. Women are affected somewhat more than men. More women are affected compared to men. More than 90% of the patients have experienced a major depressive episode. So depression is always go hand in hand with this body dysmorphic disorder. 70% experienced anxiety disorder. 30% experience psychotic disorder. Now regarding etiology, of course it is psychoanalytical theory, biological theory, genetic theory, psychosocial theory, family theory, everything explains about occur as etiological factor for this one. Then regarding diagnostic criteria, preoccupation with an imagined deficit in appearance. The preoccupation causes clinically significant distress or impairment. The preoccupation is not better accompanied for any other mental disorder. Even if he take treatment, he will continue to have such problem. Remember to differentially diagnose following conditions, that is anorexia nervosa, gender identity disorder, major depressive disorder, avoidant personality disorder, delusional disorder, somatic type. Then regarding treatment, symptomatic management is important. Antidepressants are found to be effective. Anti-anxiety drugs are effective. Then regarding nursing management, detailed assessment, planning, diagnosis and implementation and evaluation, as I discussed in the somatization disorder. So far we discussed about various conditions which has got a physical symptom. Patient is complaining physical symptoms, but actually there will not be any physical identifiable causes for that one, no organic causes, but actually it is based on psychological distress. It is the psychology, the mind that results in the problem with the mind results in physical problem. Now we are concluding with this one. So if you have any doubt regarding this topic, you can comment, and if you have any more suggestions regarding future videos, you can comment below.